Добре, дякую.
And I see that Amy Adler has joined us.
Yes, I'm here.
Hi. We will begin with Oksana just introducing a few of our Ukrainian colleagues, Amy, and then I'll ask you to just make a few statements as we discussed.
Yes, absolutely.
Thank you for making the time to do this.
I can also introduce myself. So when Oksana is busy, I think asking whether Volodymyr is available. Тож я перейду на українську мову, колеги, поки Оксана зайнята тим, щоб сконтактувати з паном Володимиром Кросієм. Я коротко представлюся, мене звати Ірина Франкова, я лікар-психолог, кандидат медичних наук, я працюю на кафедрі медичної психології, психосоматичної медицини і психотерапії в Національному медичному університеті імені Богомольця. Я також дуже рада бачити всіх колег тут присутніх. За ці роки ми дійсно багато зустрічалися в різних обставинах. Дуже приємно бути присутньою сьогодні і мати можливість поділитися своїм досвідом. Дякую.
Дякую, Ірино. Олександре, може ви також самі себе представите? Ви красивіше це зробите? Добре, а я намагаюсь додзвонитись.
Ви до мене?
Так, Олександр.
Так, мене звати Олександр.
I am Oleksandr Fedorets.
За освітою психіатр.
I am a psychiatrist.
Аналітичний психотерапевт.
And I have been working for many years as an analytical psychotherapist. I work in the crisis service, providing services to servicemen. I have published several publications in some American journals on the need to transform the psychological techniques of working with military men.
If it's possible, I would like to introduce myself also. My name is Vladislav Sinyukovsky. I'm Major in active duty of Ukrainian military forces. I'm combat psychologist. And for the last 2 years, I was active in 77 Center for Psychological Support of Ukrainian soldiers. And my interest here to listen and probably maybe to share my experience shortly, because for these 2 years I have used at least some hundreds of debriefings with our soldiers. It could be interesting to see reaction of any other, how to work with, how she will comment my experience if I will have time. So I have interest to be here and to listen and to discuss what is the most effective practical way how to support combatants after deployment. Thank you so much.
Oksana, are we ready to begin?
I think we are. We still wait. Here is Volodymyr. He has joined. Just a second probably for him to.
Okay.
Може ви його представите тоді, Оксана?
Oksana, could you introduce him, please?
Питаю, пане Володимире, може ви самі?
Mr. Volodymyr, maybe you would like to introduce yourself.
Volodymyr Korosti, psychiatrist,
Volodymyr
the Department of Psychiatry, Narcology, Medical Psychology and Social Work, Director of the Center for Mental Health of the University Hospital of Kharkiv National Medical University.
Good evening or morning, colleagues. Thank you, Oksana, for introduction.
Okay, I think we're ready to begin. Welcome, everyone. I hope that this evening's presentation will serve as an encouragement for all of us to think about ways that we can help capture information from what's been going on in the war in Ukraine and further support the advancement of not only psychology, but mental health in general. I've asked to just kick us off a few comments from Dr. Amy Adler from the Walter Reed Army Institute of Research, who was the person who first suggested to Oksana, Oli, Carla Castro, and myself the idea of today's presentation. So Amy, go ahead and offer your remarks.
I thank you so much, Jim, and thank you to the team for inviting me. I wanted to tell you about an opportunity. A colleague of mine, Tim Hoyt, and I are putting together what's called a special issue that's part of a journal called Military Psychology. And I actually, if it's okay, I'm just going to share screen and show you some things to make it a little easier. I don't know if I have permission to.
Allie can do that. Go ahead.
Okay, it still says disabled. Oh, wait, now I think I can do it. Let's see if I can figure this out. Okay, so this is just a quick review of what I'd like to mention, and that is we have this journal. It's called Military Psychology. This is what it looks like. And we've established a special issue that I think might be of interest to your team. This is available online. You can get information about the journal, and I'm just going to tell you what the special issue is. So it's mental health in large-scale combat operations. Large-scale combat operations is the kind of new buzzword, the new popular word that the U.S. military uses and other allies to really describe sort of like the kind of combat that your country is involved in right now. It's different from the kinds of combat that the U.S. and its allies have been doing up until now. So there's a short description that's available online. You can see what we're looking for. We're really looking for ways of thinking about how mental health and resilience needs to be addressed in this context, how it might need to be reimagined, how we might need to think about unique psychological demands that are not currently part of what we normally talk about in terms of publications. And really, this special issue should serve as a platform for establishing new priorities. We realize most articles won't have empirical data, but if it's possible to demonstrate what you're talking about using data, that's ideal. And one way to do that is through case studies, which led to the idea that maybe I would just mention the special issue opportunity as you're thinking about publishing case studies. You can certainly publish case studies in other locations, in other ways, but there's an opportunity here that might be useful for you. There are examples of the kinds of topics we're talking about. This is available online, so you don't need this. I don't need to go through all of it. I don't want to use up Kert's time. And I do want to say we're thinking about each article having a common feature, like some sort of image, visual representation, some sort of evidence, description of future research, and how it applies in an international context. We're looking for, we realize this is sort of last minute for you guys, for many of you, even though the call for papers has been out for a couple of months. So if you are able to submit a title by 1 February and an abstract by 1 March. We're giving an extension. We would be willing to consider that. The abstract is less than 250 words. We would then tell you, yes, this is what we're looking for. Oh, no, this isn't a good fit. And that way you don't waste your time writing a paper that wouldn't be accepted. We want to make sure you have a good chance of having the paper accepted, but it will go through peer review. So it's not just up to Tim and me making that decision. It will go through peer review. And what we would recommend is, if you're interested, please think of this not as an opportunity to talk about what Ukraine is going through, but rather an opportunity to talk about the kinds of lessons learned that you have that could inform large-scale combat operations. So it's a little different. There are opportunities, I think, to just do a more Ukrainian-focused case study, and other journals would be interested. But for this special issue, if you're interested in submitting, we really want you to think about whatever story, or I don't mean like a made-up story, but whatever line of reasoning you want to emphasize, it really has relevance to this larger scale international challenge. So just think about that. And then here's the email that you can send it to. We purposefully are trying to make it simple. So it's not, this first part of submission does not mean going to the website and being all complicated with, filling out lots of details. You can just email us, and we are checking this website, and then we will turn it around pretty quickly and tell you whether we think this is a good idea for the special issue. If we get up to at least 10 good articles, which of course I think we will, but if we get at least 10, the journal has told us that they will also publish the special issue as a book, which is a nice added benefit. But obviously not critical, but it's kind of a nice little extra piece to this. We also strongly encourage, and I'm sure Kert will talk about this, that if you are interested, you pair up with somebody who knows how to write scientifically and who is deeply, deeply fluent in English, because we won't be able to make those kinds of corrections. And so we want you to succeed, and we really value the contributions you're going to be able to make. Do you guys have any questions?
Thank you, Amy. I think that was very clear and very helpful. I don't know whether you could send me those slides that we could then post. That would be great. Thanks.
Okay, sure. All right, thank you very much. And now I'll go into listening mode and hear what Kert has to say. Thanks very much.
Kert, I'm going to let you do your own self-introduction here, and then move on with the time that we have.
Great. Thank you, Carl. Thank you, Jim. Thank you. And then also thank you, Carl and Oksana, for inviting me to speak. Good morning from Washington, D.C. It's so nice to be here with Ukrainian colleagues, many of whom I have relationships with, and it's good to see all of you as well. Today, I'm here to talk about case reports. For those of you who do a lot of scientific writing, this will seem very basic, but I present it as really a platform to broaden the discussion for this general audience so that we can all start thinking on sort of the same level about preparing mental health lessons learned through case reports. My hope is that I'll inspire, I'll definitely inform all of you, but hopefully inspire most of you to start preparing case reports for publication. I'm Kert West, and I am a psychiatrist and associate professor at the Uniformed Services University here in Bethesda, Maryland, in the US. I am a retired Navy psychiatrist, and I spent a significant part of my career supporting US Marines in combat in Iraq and Afghanistan. And while I consider my experiences unique and significant in helping combat soldiers endure the hardships of war, I am truly humbled to be in this group whose challenges seem so much greater than any of those that I had to deal with. I must tell you that although I am an employee of the United States government, what I'm talking about today are my thoughts, my opinions, and my ideas. Please do not consider them the official policy of the United States government or any of its agencies. So, why case reports? In scientific literature, the gold standard of evidence is a randomized controlled trial. But that is the endpoint of a longer history of discovery. On any given day, many of us encounter a clinical experience that causes us to scratch our head. Perhaps it's a patient who has symptoms we've never seen, or that we only read about, or maybe we never read about. Or it's a response to therapy that's unusual or surprising. It's the kind of patient that makes you want to pop into a colleague's office and tell them what you just saw. And your reaction is, wow, this is an interesting case. Perhaps you do a quick search of the literature to see if something else has been written, if there's a similar case, if there's information about how to treat such a patient. And when you look, there's not much there. So guess what? You probably have a good case report. So you should write that up and get it published in the scientific journal. But it doesn't stop there. Case reports fit into advancing science. Perhaps a year from now, maybe sooner, someone sees a similar case. They look at your case report and then they write their own. And then another one, and then another one. And after a while, multiple case reports, somebody decides to look into the condition or treatment further. That might be a laboratory experiment, a small treatment study, maybe even a randomized controlled trial. And it all started with your one case report. So let's talk about the process of building a case report. First, think about who are you writing to? Who is your audience? Who cares about a case like this? Is it something that military psychologists would want to read about? Or is it more directed towards psychiatrists working in hospitals? Maybe it's of interest to a general audience, perhaps military or civic leaders. The next step is to write down all the details you can remember about the case. This might include, and probably should include, going back over notes or getting other information from the medical record. Write down as much detail as possible. And be sure you have all the facts and the timeline of the case recorded accurately. Then think and write about how this information, this case, can inform others. Is it something that hasn't been seen before, or a new approach to a problem? How has seeing this case changed your own practice? Does this case expand your understanding of a problem? Write those thoughts down and write them in a way that might inform someone else who comes across the same problem. As you're preparing your case, I want to emphasize that it's important in the end to remove any identifying information. Preserve the privacy of the patient that you're talking about. You should discuss with the patient your desire to publish information about them. Tell them how you'll protect their privacy, and you should get their permission. The structure of a case report is pretty straightforward. The information I'm showing you here, it's adapted from the Case Reporting Guidelines website, and I have the citation at the bottom of the screen. Your introduction should start with the problem that's present in the case, and then talk about what is known about the problem, and finally narrow down to a gap that exists in that knowledge and how your case report fits. Think of this as setting up what you're going to talk about. I'll use my own first and favorite case report that I published to illustrate. In 2003, in psychiatry, we had concern about metabolic side effects of second-generation antipsychotics. They were just beginning to get used widely. At that time, some suggested that mental illness, particularly schizophrenia, and not the drugs, were responsible for weight gain, elevated lipids, and other adverse effects, not the drugs. It was the illness, not the drugs. I happened around that time to encounter a patient who had no psychiatric diagnosis and who was, by accident, exposed to the antipsychotic olanzapine for an entire year and developed significant metabolic side effects. Those were the key points I made as I introduced the case. The next section of a case report provides the details. Much like a clinical presentation, perhaps that you gave in training, but shorter, you should provide the history of the patient's symptoms and any other examination findings, what your assessment was, how you intervened, and how the patient responded. Depending on what you are seeking to present in the case, you may not include all of those pieces. Let's go back to my example. This patient, and I'm summarizing rather than read it to you. This patient was a man in his early 30s. He was referred to the psychiatry clinic because he had been inadvertently exposed to an antipsychotic for over a year. 1 year prior, he was prescribed the antihistamine Zyrtec which is important. It starts with a Z and with the letters ZY for seasonal allergies. And he was instructed to take 10 milligrams twice a day. Because of a pharmacy error, the prescription was actually recorded as Zyprexa. Note, also starts with the letters ZY, which is the trade name for olanzapine, 10 milligrams twice daily, which he was given with refills for an entire 1-year supply. This patient had no history of mental illness. When he went to his primary care doctor, a different doctor than the one who prescribed, 1 year later, the doctor quickly saw that he was not refilling an antihistamine and also noted that the patient had gained 45 pounds, had experienced elevations in cholesterol and fasting glucose, and had developed hypertension. These are all classic metabolic symptoms commonly associated with long-term use of antipsychotics. Going back to our structure of a case report, the last section should then consolidate what the reader should take from the case. That might be, why did it happen? What new science does this suggest? You should talk about the strengths or the limitations of the information you present. And finally, think about what might be done further to develop the ideas that your case presents. So going back to my example case, the idea was, this is a clear example where a patient did not have mental illness, was simply exposed to the drug and developed the adverse effect, which I presented as a counter to the argument that a patient with schizophrenia is prone to gain weight regardless of medication treatment, and especially with medication treatment as part of their illness. I got the permission of the patient to publish this information, and I prepared it with a colleague, and we submitted to the American Journal of Psychiatry, where it was published as a letter to the editor in 2005. So looking at this structure, this outline that I present you, it's helpful to think of it, the introduction is like a funnel. It's taking your idea from the broad world where it exists and bringing it down to a point of, here's a gap in knowledge that I want to talk about through a case. You then present the case, and as you get into your discussion, think of it as flipping that funnel over, and you're taking the very specific information your case represents and bringing it back out into the broader scientific landscape. The document that I share here is just one example of a checklist that you might think about using as you prepare a case report for publication. This is just one format. It might not be applicable to the case that you wish to publish, but you can find this at the website for case reporting guidelines, which is the same one that I previously cited in the last two slides. Finally, and I'm really grateful for Amy opening up this discussion, talking about where we might publish our case reports and actually asking us to publish our case reports. I offer here some additional places you might consider publishing your case report. It depends on the content. And this is where working with Jim or Carl or Amy or myself, we're happy to help you start to develop ideas about where your case might fit in the broader literature. Or again, for those who are in academic settings on this call, you probably have a broader list that is beyond the English-speaking literature, which is where my familiarity is, again, to help your colleagues. And that is actually why Jim set this up the way he did, to bring in several colleagues to talk further and help develop ideas for cases that are relevant and where we might consider publishing them. With that, I'm going to stop my portion of the talk and I will hand it back over to Jim and Oksana.
Jim, you are muted.
Oksana, let me ask you to invite our Ukrainian colleagues in any order to comment and offer their observations.
Dear colleagues, now over to you. So from what you've heard, what questions you have, whether this information was useful, whether it is applicable to your experience, any questions, any comments, over to you now. If I may, good evening, dear colleagues. If our dear English-speaking colleagues, like I'm sorry, I'm going to speak Ukrainian. It's a very interesting topic that we are discussing today. It's a case-oriented approach of learning experience, because it seems now that in our practice, at least in my and colleagues that I work with, other psychologists and psychiatrists, that's exactly what we've been collecting from our day-to-day work, because there are many examples which are very specific for full-scale war period, and some facts, some clinical cases of comorbidities, combination of traumatic events, contusions, and it all can be mixed also together with different psychotropic substances. And also we have some clinical situations when basically people are deployed and they are serving, but they have different mental disorders. Some, when people got mobilized, they hadn't thought about their conditions and they wanted to serve, so they maybe didn't disclose all the information about their mental disorders. And so this is very So these are quite unique cases because usually people are selected to serve in the army after very thorough medical checkup, including psychiatric check. Also, if use different psychotropic substances and can be different during the military service, and this is just what came to mind first, but there are many cases and many other examples, and many cases we just forget about because we have extremely high workload now, so we just forget it working on the next case. So I believe that it's very relevant information about this approach that what we need to do to describe cases, to analyze them, to work for supervisions, intervisions, also publications where it can help inform our professional community and about certain facts and aspects. And I guess where we have certain opportunities. So using cases now is introduced into medical education in medical universities. And one of the tasks is to select cases for learning purposes, which in one or another format can be used as in videos or in text format, because right now we don't have the Ukrainian materials which would be approved for this course, and all professors they ask for Ukrainian materials which are based on day-to-day clinical practice in Ukrainian context. So we have this task. Universities are now engaged into preparing this material, and there is cooperation with clinical community to collect these cases and to present them in the proper manner. Maybe we can think all together how we can combine, or how can we actually let people meet people who have good cases and people who can help with describing them correctly and preparing them as proper educational materials. And one more thing, this is telemedicine. Probably it is relevant for many, including psychologists. They practice more, they work online, and now psychiatric online consultations are also becoming more popular. When it's a consultation with a family doctor, psychologist, and then psychiatrists can provide consultation online because they are not physically available for this interdisciplinary discussion.
Питання в тому, що з одного боку легше, здається, записати цей відеоматеріал прямо під час консультації. Ну і з іншого боку є певні труднощі, тому що це відбувається досить швидко на запит, і там з узгодженням згоди, наприклад, пацієнта про запис поки що я ще не дуже визначився. Можливо, в когось є щодо цього свої зауваження, досвід, то дуже вдячний, якщо озвучите чи сьогодні, чи в подальшому в переписці. Ще раз дякую за цей такий.
And I would like to thank once again for presenting this classical approach to cases, which is very useful. And it is important that we move towards further implementation of the case-oriented approach.
We have some translation issues.
Can you hear English translation?
People hear, they
Вже все
hear.
нормально, вже все нормально. Все супер.
Okay.
Everything is okay. Good.
Super.
Та я вже все сказав. Дякую за увагу.
That's all from me. Thank you for attention.
Так, Ірино, прошу.
Хочу подякувати організаторам ще раз.
I would like to thank the organizers for the invitation and for presenting this important topic, and I'm happy to take part in this work and publish the experience I have accumulated, and I would like to thank Kert in particular for a very clear presentation. In reality, when I studied, I have never heard a lecture about all the components of this process, and I will use this information when preparing the article I plan to publish. This regards the lessons learned and how they could be used for myself and other colleagues, including colleagues from other countries, and the way how these lessons learned could be used. So thank you for such a structured presentation. When I was listening to Volodymyr, many thoughts were coming to me about the cases that would be interesting to publish, to share, and I would like to discuss them briefly so that it might inspire others that have similar experience. The first thing I thought about is as follows. I do not work often with veterans or the servicemen. I work mostly with adults and children. But in working with adults, we often come across the grief, and within the framework of a special project, we have been delivering special sessions for those who lost their loved ones during the large-scale invasion, and the loss could be definite when the loss of parents or a partner is confirmed, but also we work with an indefinite, not confirmed loss. In all these cases, when providing support to these people, we've discovered there are almost no protocols on working with unconfirmed loss. If you know about such protocols, I would be grateful if you can give me this information. And we work both individually and in group mode, but we prefer group mode because we have not come across any protocols on working with unconfirmed loss in groups. So we work with those who lost a partner or children or parents, and from this group work we have many observations which could be grouped in a case description, in a case report. So this is one thing I wanted to tell you about, and maybe you have some similar experiences in this respect. And two other examples. Recently, I conducted a brief review of literature on new types of weapons and the related to them new symptoms like drone phobia. This is the new term that came into existence in these years, and we use it. And this definition of drone phobia doesn't exist in any English-speaking sources, and I thought maybe it would be useful to write a case report on use of new weapons and related symptoms, so that other scientists or clinical therapists could refer to these cases. And the other thing I wanted to share, and it would be good to hear your experience in this respect. There was a coincidence, and I was invited to have a look at the thesis of a colleague which studied different types of PTSD treatment. In particular, the causes for the treatment interruption. She was using the different aspects, use of EMDR, prolonged exposure, and other factors which influence the interruption of the therapy. It was a systematic review in the course of which over 40 studies have been reviewed, and she noticed that for EMDR, it is typical that people who have problems with employment, they interrupt the treatment more often. And just one of these days, I heard at the supervision about the case that a client has to stop his EMDR therapy due to problems with his job. And my colleagues didn't know about this research. On the other hand, the scientists do not know about the practical implications of their research, and somehow it is important that this gap is bridged and these two parts of the story meet each other and collaborate better. I think that this is also an interesting topic. Thank you for attention. If I may, I would like to offer a comment. Technical information about working with unconfirmed loss. I know that International Red Cross colleagues have started working on this, and they have already organized a 3-day workshop. I can't tell you all about their training program, but it is possible to get more information, and I could share it at our next meeting. And the second thing, as regards the drone phobia, I haven't heard this term, but for sure the phenomenon exists. And another phenomenon that I've witnessed during this war is the phobias related to use of poisonous substances. It's hard for me to identify these substances because those are not classical poisons with defined lethality action. On the other hand, those substances are not pure gas, tear gas, according to the registered cases. So those substances are something in between, and they are used by the enemy quite a lot in this war. And the result of the impact of these substances, if no protection means were available, is as follows. Like we have some cases where a military man gave his anti-gas protection mask to his friend, and he described his condition. He felt all his limbs getting numb. So he seemed to have a paralytical symptoms, and after that he developed phobia also in respect of different smells as a result of this heavy experience. So thank you for this definition of drone phobias, and to that I would like to add some kind of gas phobia. And I believe that the scientists and the clinical practitioners should get together and work together in order to combine their competences and skills. I would like to thank the colleagues for the offered assistance in publishing our case reports. It will be easier for us to publish through our joint effort. And maybe those cases will set a start for further scientific research. And then the prevalence and frequency of the cases could be explored.
Kurt, you wanted to add something?
Yes, thank you. I want to thank Dr. Frankova for pointing out something that I overlooked, and it really resonated with me. The idea of a case report as a form of supervision, perhaps for others who are in independent practice and encounter a case and are not sure what to do, that a case report provides that mechanism to give somebody a boost or an idea. And I also want to thank Dr. Korosti for his insight and his wisdom on this. I wanted to suggest some areas, and I see that Dr. Martin had dropped some suggestions as well in the chat, but some suggestions for areas that, from my own personal perspective, I believe we in the United States and perhaps the rest of the world would like to learn from the Ukrainian experience as it relates to large-scale combat operations. I think the idea of grieving unconfirmed losses is a very important area. And as a matter of fact, I will probably connect you with somebody at our center if you aren't already connected. The idea of supporting not necessarily even combatants, but communities that live under threat and helping people manage the psychological consequences and continue to live their lives and contribute to their communities, even though they may feel threatened. And where does psychiatry and psychology fit into that effort? Cases like that, I think, would be very informative. And as Dr. Martin had mentioned, the idea of supporting soldiers who are experiencing their own trauma while at the same time possibly experiencing the trauma of loved ones in a different location, and how do we support and intervene with those individuals? So thank you for the back and forth. This is so helpful to me.
I would just like to, this has been fabulous, by the way, and I just want to
Я
thank Kurt again for his great,
хочу сказати, що це
his
те,
great
що відбувається, це
presentation.
просто чудово.
Just in terms of the special issue, so
Що
there are case studies that
стосується
Kurt talked about. These ideas on
спеціального
case studies are
випуску,
really, really important and can
то
contribute to the
презентація ваших
special
кейсів
issue.
була б справді дуже важливою.
But when I spoke to Amy, she's also
Коли
very
я говорив
interested in if there's any
з
leadership
Емі,
issues that
вона
emerged
говорила
in
про
these
те,
sort of large-scale combat operations. And
що вона
leadership
дуже
issues not just from
зацікавлена
combat
загалом
side, but from the behavioral
в
health side.
запуску
What special
роботи
leadership
над
lessons
цією
learned are there?
темою і над темою лідерства під час
That would also
широкомасштабної
apply
війни.
to any special organizational challenges or
І сюди
management
стосується
challenges
і
in these large-scale combat
виклики,
operations.
пов'язані з організаційною роботою, з управлінням
One
під
thing that
час
we talk about
широкомасштабних
all the
військових
time
операцій.
is psychiatric triage. But we
Ми
didn't really encounter that
говоримо
a lot in the
про
wars in Iraq and
психіатричну
Afghanistan that may be more
тріаду.
important in these types of operations. So
І тому
do
що
think about
і ми
it
знаємо, що
from,
наш досвід
you
такий,
know,
як в Афганістані, є дуже
beyond
важливим.
individual clinical studies. And just really a question for Kurt, and I think Alan Peterson is also on. I recall reading case studies where there'll be like 3 similar cases published in the same report, where you would set up the problem, case study 1, case study 2, case study 3, and then there would be like an integration of all of those cases. And it sounds like there's a lot of similar experiences that might be combined in a sort of case study format. I guess I'm just putting that out there. I know that's beyond what Kurt talked about, but it sounds like there's a lot of you with a lot of different experiences that are converging on similar topics that can be combined into, quote, a single case study paper or report that has 3 or 4 case studies in it. But I'll shut up there. But this has been fabulous. Thank you.
I would agree 100%, Carl. And that's what I would call a case series. And so it sort of in the hierarchy of evidence, that's one step up from a case study or a case report, a case series that incorporates similar elements. And you're absolutely right. That's another way to submit.
Колеги, знову бачу повідомлення, що щось не так з
Dear
перекладом.
colleagues,
Скажіть, будь ласка, як у вас переклад чи не
is
чути?
everything okay with interpretation? Can you hear the interpretation?
Напевно, чути. Так, Олександр, прошу.
I think we can hear the interpretation. There was some overlay of the Ukrainian and English for Carla Castro's comments.
Окей. But now it's fine. Супер. Олександре, прошу.
I would like to thank our American colleagues that they found the time for us, and they are trying to institutionalize our work and make us more civilized. It is hard for us to do so because many of participants of this discussion, they never dreamt about being military psychologists, but in one way or another, that's what we need to learn to be. Another difficulty, and these instructions, guidelines that you provide, they are very important, but the other difficulty is that in this process of the war, which influences us a lot, it's very hard to find space to stop and to think through certain stories, because we have story after the story and we don't have enough mental space just to think everything through. And I would like to draw your attention to a more wider context, because when we talk about therapy, about certain clinical cases, the relationship with patient, client, military, and the psychologist, we are in. There is social context plays a big role. Social context for the patient. So how long the military is serving, what relationship they have with their commanders, social situation in the country, how civilians are behaving and treating them, and attitude of other countries and or leadership of other countries, what they say about supporting Ukraine. And when we describe these cases, we need to take into account this wider context, because it does influence the situation. If I may, I believe that this context, cultural aspects are very important, and we have some famous, some special relationship with some people who have power and authority. And this special relationship, they are dictated by our past, where in the past the leader was not the one who would protect, but rather than who is vice versa, like they might punish, and it does not help build relationship. It doesn't help leaders. It doesn't help the subordinates to build this new relationship, and I believe that if you work in this area, so Vladislav had to leave. I believe that he could have shared a lot because he works with this experience a lot.
Jim, please, you're welcome.
Oksana, let me make just a brief comment on some of the thoughts that were offered a few minutes ago about the high stress situation that many of my Ukrainian colleagues find themselves in. I would like to suggest that trying to find a little bit of time to do a little writing is actually very therapeutic. and will be very helpful to many. I would also suggest that one way of doing that, and I would offer Kurt an opportunity to comment, is the idea of keeping a journal. So even if now you're not able to pursue all of these things, that some of these thoughts and ideas won't be lost. So the whole notion of journaling, again, I think is very therapeutic.
Ірино, кажіть.
Iryna, over to you. Jim, thank you for the invitation. I just want to say about our pain, about my personal pain. I have time to write the article when I have a vacation or my winter holidays. Also, I can reply to the comments of the reviewers also around this time, which means that I can submit the article. Then it's painful that it was not automatically accepted. Then to see like 5 pages of the comments of those who review it, and then I need to put aside for another half a year because then I would not have time to change something. And I believe it's a very difficult topic. Yes, so we came here together to discuss how to submit articles, but we do need to understand how the process is built and how much time it takes. And yeah, sorry, I had to say that. It's a big pain for me. And I believe that Carl's advice is similar. Yeah, so to create certain abstracts. So it's a good maybe idea, just like to just stop for a second and to write down. So write an abstract, like, so only 250 words, it's not the whole article. And then you just need to add a little bit more in March. So thank you for this possibility of this narrative psychology where we can just organize our thoughts. And my question is to our international colleagues. What if you get 100 articles, not 10, as you ask? What are you going to do with other articles if you get too many for this special edition?
Well, one of the things, don't forget that Amy pointed out, or no, I'm sorry, Kurt pointed out in his presentation that the special issue is 10 articles, but there are 7, 8, 9, 10 more journals that will publish case studies than just this special issue. So maybe you won't be in the special issue, but you'll publish the paper someplace else. So that's fine. Don't look at it as, oh, there's only 10 papers. We got to find a spot in there. Think beyond that. If it's a good story, it's a good story. You know, every paper has a home is what I always tell my students. It's just sometimes finding the home for the paper. So don't get discouraged. I would like to take a moment. Alan Peterson is here, and he is also an expert on case studies. And I just read if I don't know if it's the text, the comments or the chat's being translated, but he's not just an expert in case studies, though. He's an expert on RCTs and all kinds of, so from the gold standard to the beginning of the idea, and he has offered to serve as a mentor or advisor for anyone who's interested in case studies. So Alan, thank you for that. You want to say something, Alan? I'll give you a few minutes to say something. I'm sorry we didn't see you earlier and acknowledge you properly. So my apologies for that.
Thanks. I'm Alan Peterson. I'm a retired Air Force clinical psychologist. I served 21 years on active duty and had 3 post 9/11 deployments. I have been involved in doing case studies for many, many years. I've published about 20 case studies, and I think all of the descriptions of ideas about possible papers and case studies, I think those are exactly the types of contributions that are needed. And I really appreciated Kurt's presentation, a very nice overview of that. And then the ideas that people have, I think those are directly related to what is needed. So part of what I'm offering is if anybody wants individual mentorship or help in the development of a paper, I'm happy to do that. So I put my email address in the chat, and if someone wants to reach out to me, I'm happy to provide mentorship in the development of a paper. Thanks.
You know, just I'm just going to plant another thought why we have folks here. I remember in some of our earlier webinars that we talked about resilience and what that would look like in these sort of large scale combat operations. And so, and I know a lot of you have thoughts on that. So please don't, you know, when you, again, take a look at the list that of topics that Amy provided. Resilience was one of the important ones, the preparation for going into large scale combat operations. You know, no one plans it to be long scale, prolonged combat operations, but that's where you end up, and you want to be prepared for that. And so, and I know you have lots of lessons learned there because I've heard them in, you know, over the last couple of years we've been doing these. So for those of you who have thoughts on that, so you can be thinking that way too. And one of the topics that often isn't really addressed is resources. The resources necessary to support both the military and the civilian. It was sort of alluded to earlier in terms of, you know, how many of you, when you were in college, university, planning to be a military psychologist or military psychiatrist or military social worker, or just involved in the military? And here we all are. So how do you prepare for that? And how do you scale up for that? You have a lot of experience doing that. And I would tell you how we did it in the Iraq and Afghanistan war, and it wasn't pretty. In fact, we had clinicians who were on active duty. I don't think this has ever been written about, Alan. I'm looking at Alan and Kurt. I don't think this has ever been written about. We did not have behavioral health professionals, both social workers, psychologists, and psychiatrists, who even knew how to do a diagnosis of PTSD because they never seen it before. And so that was a big learning curve. I mean, a lot of this is very steep learning curve. I mean, we're not there anymore, but and now one could argue that we're overdiagnosing veterans with PTSD because, you know, of the media and the presumptions that go along with that. So these are just real lessons learned that we can, you know, everyone can learn from the experience in Ukraine. I know, you know, the U.S. is very, what can America take away from this so we can prepare better next time? But every military can benefit from this to prevent unnecessary suffering that happens in war. I mean, deliberate suffering happens, but then there's a lot of unnecessary suffering that happens also. And, you know, one of the things we also always want to be mindful of is what can we do to prevent all of this unnecessary suffering? And of course, you know, as mentioned by many of you, the suffering among children, especially non-combatants, etc. So anyway, again, I'll be quiet, but this was just so refreshing to hear this and hear all the ideas that you all have. Is that it? Are we out of ideas, out of discussion? I know we're not out of ideas, but maybe we reached our limit of discussion for today.
I'm happy to add more, but just like we still have 15 minutes, right? Yeah, and thank you so much for raising this issue about resources. So it's not just the scared resources in terms of people who can train others, limited time, right? So there's no time also, but indeed the whole country that is affected by that full-scale invasion, and also the economics, right? So, and also the healthcare system is affected. So that's I think that's something that might characterize this large scale operations that is very different in with, yes, if you would compare with outside country missions and deployments, when soldiers or veterans kind of go back in a safe environment, their family is in safety, the health care they might receive in place, there are resources allocated for that. I don't think we have a solution or any advice or recommendation, or maybe we are. Yeah, but yeah, this adds a lot.
In these terms, full-scale operation for Russian-Ukrainian war is so mild term, because now this is a question of existing of nation, existing of country. So it's not only a question of military operation. This is existing challenge for all of us, for all nation. But it was interesting what mentioned about resilience, and it's important that preparing for full-scale operation in Ukrainian war, we're not prepared really to start of the war. We absolutely were not prepared, except of some steps from exactly from army, from military personnel. But in terms of psychological preparations, very relevant experience in preparation of Kursk operation. And our colleagues, military psychologists who are present here and or not, have very relevant experience, and it were many questions from soldiers before start and during this operation, because it's completely new, and and our soldiers need to change their mind, change their consciousness, because Ukrainians are not ready to step to land other countries and other nations, and it will be necessary to establish this understanding why this mission is necessary for defend of our so this is really relevant experience of operations. And now thanks a lot for this call for discussion of case-oriented lessons learned approach, and it's interesting to have a feedback from Ukrainian colleagues how much it interesting, and is it are you interested to continue this discussion, maybe more detailed, maybe in some special points, special approaches, some details more specifically. So if you have some ideas or needs, please text that or say that we have maybe a couple of times for this feedback.
Dr. Korosti, thank you for your thoughts on that. I'm thinking about an earlier observation you made about individuals who were mobilized into military service with existing illness. And I bring this up as another opportunity for case reports. And I bring it up as an opportunity for case reports, both in the circumstance where entry into military service may have actually served as a catalyst for remission of illness and finding resilience, and contrasting that with individuals who entered military service and experienced worsening of their mental illness. I think that would be fascinating data to present, even on an individual case basis. Thank you.
Thank you, Kurt.
Андрій Карачевський, будь ласка.
Andrei Karachevsky, the floor goes to you. Good evening, everybody. I would like to thank all the colleagues for the idea. Maybe some of the colleagues here have cases to present, but they do not know English good enough. So maybe Oksana and Volodymyr could agree to help them to write these cases in English so that they could be published. What do you think? Well, this is a good idea. If we work as a team, we can do it. If we join our efforts. I completely agree with Andrei's idea. This is very precious that we don't lose experience of those colleagues. And I have an idea in response. I'm sure that we will be able to organize some translation support for translation of the abstracts, and maybe we could develop a template on the basis of the care requirements that were presented today. So this is a good idea. Great. Then maybe under a post you should publish that military psychologists could send their cases also in Ukrainian. And we also would like to thank Alan for offering his mentorship. Good evening, everybody. Do we have interpretation? Yes, can you hear the interpretation? Can you hear the interpretation? Yes, okay. I would like to thank for the organization of this event. Volodymyr Korosti just took the words from my mouth regarding the translation of the case reports. This is exactly what I wanted to say just a minute before. Dear colleagues, we have planned another meeting related to this topic in 2 weeks so that we can have an in-depth discussion for the would-be authors. So in 2 weeks, we would like to delve even deeper in this topic. We have a template for case reports for supervision. And maybe Andrei Karachevsky will get involved. We will change it around a bit and we can prepare it quite quickly.
And just a quick reminder, we have, I think, 1 February, a due date to Amy for a title. So that's all we need is a title and I think authors, so potential authors. So the title doesn't have to be the final title or the final authorship's determined, but Oksana, if you and Ole or anyone could collect the potential titles and, and I don't know if we'll need another meeting, but we really want to get those submitted to the website because that's what they're going to look at to see. And then we have another month to generate an abstract. So we've got like a week and a bit to generate a title and then a month to generate the 250-word abstract. So anyway.
Now, let me build on that with a special invitation to any of our colleagues here who have not written before, who have not published, who may feel anxious or a bit timid in doing this. This is not the time to be timid. I'm sure you've had important experiences. And if you would share, as Carla suggested, a title, there are many of us that are willing to work with you and further develop your ideas and your experiences. So a special invitation for anyone where this is a new experience. Know that you will have support and we will try to assist you.
Yes, it's clear about the titles till 1 of February, and seems our discussion going on a little bit later to other branches about clinical cases collection. Yeah, not only for this proposal, but more generally. Yeah, but for titles, yes, deadline is 1st of February, and after we will have time 1 month for finalizing of abstract. Yep.
Oksana, I'm watching the clock. Let us know when you think we should tie this up for today and end for today.
I think that's it. Колеги, якщо є ще якісь питання, коментарі такі наприкінці, перш ніж
So let me again thank Kert for a wonderful starting point. And Alan, we're going to be very interested in continuing with these ideas under some of your mentorship. And I'm thrilled that we can do this. Again, my last comment is I know there are important things happening in Ukraine, things that all of you have experienced that will have great value to many others. And I hope that we can be helpful in capturing those experiences. So, Oksana, I will let you end this with any final comment.
Just thank you for making this session for us, and let's hope that we will have it continued and we will go deeper and we will have really a collection of publications from our colleagues. Thank you very much.
our best to all of you.
Thank you.
Nobody didn't.
Дякую.
Thank you. See you next time.
Дякуємо, до зустрічі.
Thank you. See you next time.